Good afternoon here. It's Olivia. I'm known as Olivia K on Facebook, Ollie K on Instagram, and WarmYam9800 on Reddit. So I go over nursing materials and NCLEX related materials for RNs and PNs. And I'll leave the links below so you can find a way to reach out to me so I can go over your CPR report or help you with anything that's nursing related. I also have on the side reality related content because I react sometimes, and I do have a whole Love is Blind playlist, and then I'm going to react to Temptation Island. So let's get started. So I'm making a series of high yield meds every nursing student or person taking the NCLEX should know. So I've done cardiac, so today I'm going to do insulin as promised because I do have some time. So insulin is a highly tested subject when it comes to NCLEX and even nursing school. So for those who have ATI, they're very important that medications that you should know. Sorry about that, tongue slipped. So if you follow these tips I'm about to tell you, I guarantee you will almost never get an insulin related question wrong again. So for starters, for insulin, you need to know your types of insulins, right? And there are 4 types that I'm going to go over. So that's your rapid acting, short acting, immediate, and long acting. So for rapid, I want you to remember this acronym, and every time you see a question related to one of these, it will click. I promise you that. So the acronym for the rapids I usually like to remember is LAG, okay? And so that stands for Lispro, Aspart, and Lulusilin. I am very bad with saying not trading. I'm horrible with saying certain medication, so bear with me. Okay, so with rapid, I need you to remember that the onset is 15 minutes, and then the peak is about an hour, rather than the duration is 3 to 5 hours. So with this one, you must give this within minutes. You don't have 10 or 15, 30. You need to give this with food after you give the insulin within minutes, because the patient is going to become hypoglycemic, okay? They're going to be hypoglycemic, so get the food tray ready, or I'll tell an example. I do see a patient every now and then, and he needs his insulin. So I have to be there within 5 minutes before breakfast or dinner. So I will check the sugar. I administer the prescribed insulin. So he has Aspart. So I always give that to him. And if you don't know, Aspart is also Novolog. So that's the brand name for it. So I give that, and then he eats afterwards. So that's usually how it works, okay? So remember that rapid, eat immediately after you give the insulin. Then you have regular, and that's only, that's short acting. Sorry, I gotta make sure I get my ducks in a row, and then I'm giving you the right information, okay? So with this one, this is 30 to 60 minutes onset. Peak is 2 to 4 hours. Duration is 5 to 8 hours. Okay, and this is the only insulin, right, regular, that you are going to give with IV. The rest is not IV, okay? And before I go on, your lag and then your regular, those are your only insulins, I believe, that have a sliding scale that you need to follow. With long acting, which I'm going to get into, it does not have sliding scale, because that doesn't even have an onset and peak, okay? MPH, so that's your cloudy. That's what you're going to mix with your regular. The onset's 1 to 2 hours. Peak is 4 to 12 hours. Duration's 12 to 18 hours. okay? So I will get into the mixing after when I'm done with the long-acting. So your long-acting, I need you to also remember an acronym, or like a special kind of saying, GD, or what I like to say, God damn, or God dang, right? So that's your Garglin and Detromere. Okay, those are your long-acting. It's 24 hours. That's the duration. There's no peak to it, so you don't have to worry about that. All right. So when it comes to mixing the insulins, right? You typically will mix the regular and the NPH, and I used to do that back in when I was doing clinical, and I mostly give like the insulin pens right now. So I haven't done the mix in a long time, but here's a acronym I need people to remember. So it is NRRN. So NRRN. So that's your NPH, regular, NPH. When I say that, it means you're inserting the air to the NPH first. Then the second thing you're doing is inserting air to the regular. You draw the regular, and then you draw the NPH. The reason it's done this way is because you don't want to contaminate the regular insulin. That's why the NPH is first. And the regular is clear, crystal clear. Okay? Okay, so another point I want to bring up is this will be definitely NCLEX related material, so pay attention to what I'm going to say. So remember I said definitely know their electrolytes, correct? So the one electrolyte that's going to be important when it comes to insulin, because they have an important relationship, would be the potassium. And why would that be important? Okay, hold on. I want to say this real quick, and then I will tell you why. If a patient goes into DKA, insulin's a second line of treatment. It also can treat hypokalemia. Why is that? Because the insulin is going to push the potassium back into the cells. So this is what I need you to remember each time you see a question regarding potassium. So if a patient has very high blood sugar, say 600, and they have like aches, and then they're showing symptoms of DKA, they're going to get normal saline first, IV. Yeah, normal saline, right? Normal saline first. Okay, maybe saying it wrong, so you can correct me. And then they get insulin after the fact, because it's going to bring back that potassium back into the cells where it's needed. All right, so also keep in mind with your hypoglycemic protocol, it is 15 grams of carbs if the patient is conscious. So typically, if I have a patient that's hypoglycemic, which I don't often see, they will typically drink juice. Like, again, there's another patient that I have where we get him up in the morning and his sugar can be pretty low. So I usually encourage just to have, hey, give him juice, give him some orange juice, and then I'm going to check him in 15 minutes. And I usually stay because I want his sugar to be where I'm comfortable to give him his insulin. So I wait and I wait and I wait. And sometimes it'll take me at least 2 or 3 tries before the sugar gets to where I want it to be. So then they also have glucotabs. Like I have another patient that has glucotabs and carries it with her because sometimes she may get hypoglycemic rather. And if the patient's unconscious, you give glucagon IM, or you're going to do D50 IV. Then one more side note pertaining to this. For type 2 diabetics, they take metformin. Now, with metformin, there's only one time it needs to be held, and that's if they're getting an IV contrast dye or they're having some sort of like procedure. So you may want to hold it for 48 hours because I forgot to read them. I'm going to actually put it in the comments and if I figure it out. But I know you're not supposed to do that. There's a reason for it. And I used to know it. All right, but I'll put it down there in the comments below and description. But that's all you need to know for now, and I will talk about antibiotics for my next high yield information. So take care and happy studying. Have a good one. Bye.